Yuko, for the movement disorders, the PowerPoint slide that shows the anticholinergic or the treatments for them, do you want us to know the oral and IV doses?
No, you don't need to know the doses.
Okay, so just like the generic, classification and what they're used for?
Yeah, basically it's going to be just the benzotropine and diphenhydramine. Those are the two most popularly used drugs. When I show you this video, he's going to talk about giving amantadine, and I can't remember what the other drug was as well, but just remember the diphenhydramine and the benzotropine, okay? All right. I don't know, let me see if I can get into this without messing stuff up. What other questions did you have? None? Y'all understand the EPS?
I have a question, Yuko.
Yes.
For the book, because I know that gives a little more info for the movement disorders, there is something that said like the vehicle is hit for one of them was like sesame oil. The other one was like a capsulated type thing that relates to how the medication will be distributed to the body. Will we need to know that?
No.
Okay.
No. No. Just, just FYI, things like lorazepam, any of the LAIs, the injectables, long acting, are going to be suspended in like sesame oil, and you literally have to stand on the plunger to get it in. Remember that the more viscous the medication, the bigger the bore of the syringe that you should be using. So if I give stuff like haloperidol D, I never use a 3cc syringe. I always use a 5. Okay, because of the end pressure. Because if you give something thick through a thin syringe, the end pressure is high. You're going to tear muscle tissue, and that's what causes the pain. If you give it through a 5cc syringe, it's going to be easier to push in, and it's not going to have so much end pressure, and it's going to do less damage. Okay? All right.
Yuko, I have one more question about anticholinergic side effects. So can you, in the book it says that, like, I guess I just want to understand, so with antipsychotics, anticholinergic side effects occur with mostly like using all of the antipsychotic drugs, right?
Yes.
Okay, and so then if somebody is experiencing like any of these EPS, like movement disorders, and then they're also taking anticholinergics to diminish those effects, then is that when you can end up with anticholinergic toxicity?
You sure can.
Okay.
Good way to put it together. Very good. And don't forget the antipsychotics, antidepressants, antihypertensives, all have anticholinergic activity. Let me share my screen.
Yuko, what was it? You said antipsychotics, antidepressants, and what other one?
Antihypertensives.
Antihypertensives, thank you.
Yeah, sure. All right. Y'all can read your thingies there. Any questions about the dyskinesia, dystonias, tardive symptoms?
You go ahead. A question about dystonia. What is like the first symptom you're going to see that you're going to be watching for? Or is it just like overall muscle tension that they can't control?
Dystonias are acute, so they're going to be rapid onset. So let's say you're working outpatient surgery and you give a dose of Phenergan. And if there's going to be a dystonic reaction, you'll literally see the patient begin to draw back. their jaw will clench because it's cramping. And then they'll look at you and they'll go, I can't relax my jaw. And you'll start to see them drool. It can happen within a matter of minutes. Okay? Good question. All right. Any other questions about any of this? Did somebody just hear a ding or was that just me? Okay. All right. Top two anticholinergics that we use, benzotropin and diphenhydramine. Okay. In the PowerPoint, you'll see the gentleman talks about trihexyphenidyl, which we very seldom use, and amantadine. And I can't remember the other one that he mentioned. All right, any questions about any of that? Any questions about dystonia? Dystonic reactions? So remember with dystonia, they can have laryngospasm. It can turn into a respiratory emergency, right? Because they can't breathe. Not going to be able to swallow. Ocular gyrate crisis, if you ever work night shift and you see an ocular gyrate crisis, it's really bizarre because they're walking down the hall and their eyes are literally locked in the back of their head and all you see are the whites of their eyes. So it's kind of like something out of a scary movie. But if you ask them to bring their eyes midline and look at you, they can for a moment. And because of that, a lot of nurses will say that they're faking it, but they're not. So what you need to do is give them an IM anticholinergic. Okay? Any questions about the dystonia? Make sure you look at this part. How about Parkinson's, pseudoparkinsonism? Looks just like Parkinson's disease. I'll look on YouTube and see if there's any more videos that I can post that might help you. Okay. Pill rolling, that's where they do this. Okay. With their hands. Cogwheeling, if you take your thumb, you put it on their elbow, you take their hand in yours and you tell them, go limp and let me move your hand. While you're holding their hand and their elbow joint and you move it, you feel it ratchet. It'll go like that, okay? Just like the ratchet when you're using a socket, okay? But you'll feel it ratchet. That's why you need to do the AIMS, especially if they have Parkinson's, because how do you know that this isn't related to the Parkinson's, or is it because of side-effected medications, right? They get the fascinating gait. Remember, they lose the ability to swing their arms through when they walk. Okay. Okay. They slow down. Rabbit syndrome. They look like a bunny. Okay. All right. Make sure you look at this part right here. Okay. Akathisia, what I call wakathisia, because they gotta go, go, go. Okay. Very debilitating, very exhausting. Okay. And they're the ones who do the sit down, stand up type of thing. Okay. Any questions about pseudoparkinsonism?
You go. So if somebody has they're on long-term use of these drugs, antipsychotics, and they're getting dystonia or akinesia, it says it's going to have long-term effects if you don't treat it. Are they also on an anticholinergic while they're on the you can't just take them off do you just take them off the antipsychotic to avoid these? Okay.
Yeah.
This is more to stop this than it is to, okay.
Right. A good nurse is always going to get a PRN anticholinergic order. hold on, I need to see. All right. So anytime I have to give an antipsychotic, I always get a PRN anticholinergic order. Okay. Especially if I ever have to give it IM, I'm going to get an anticholinergic order to go with it. Okay. Just to counteract the side effects. And I do ask for two of them. I do ask for the benzotropine, and I also ask for the diphenhydramine, because my train of thought is, if I need to give them an antipsychotic, let's say they get agitated, I always ask for an antipsychotic IM as well. So I'll ask for maybe haloperidol IM. And so if they get psychotic and they get agitated, I can legally give them a B52 because I've got the order for the Benadryl as PRN, right? I've also got the order for the haloperidol as a PRN, so they're legal orders, right? I'm not doing it as a chemical restraint, okay? So you also have to be able to think ahead, okay? All right, any questions about akathisia? Okay, tardive dyskinesia usually hits in the face, mainly the mouth, okay? And also in the trunk. So they do things like the fly catching. They look like a frog. You know how frogs stick their tongue up, catch flies? Lip smacking. Now, the problem with the lip smacking is that it can be very subtle. And that's how it gets missed, okay? Or the lip puckering. Or licking. And, you know, with it being so dry, people constantly are licking their lips, right? So you can miss it because you can think that's exactly what they're doing. It can be things like eye blinking, right? So the thing to tardive dyskinesia is early detection. All right, if you don't catch it early, it can become permanent, especially in the elderly. Okay. All right. Any questions about this? Thank you. Okay. All right, so when I talk about lateral jaw movements, like you ever see a camel? Oh, camel chews. Okay, they do that lateral movement. Okay, the grimacing. Okay. Retrocollis, where they actually bend backwards and they're walking. Okay. Pelvic thrusting, which can be very, very misperceived, believe me. Okay. I think it's interesting that it usually affects people who have brain injuries. And most certainly we know that it does affect people in long-term facilities because, I mean, how well are people in long-term facilities managed, right, or observed? They aren't. So, yeah. Okay, and it talks about the abnormal involuntary movement scale, right? And this is what it was designed for. There is a current medication out for tardive dyskinesia, but it's so new and there's been so many adverse effects that it's not being used. Yeah, Christina, I would definitely know all the signs and symptoms for each movement disorder, okay? Now remember that when patients have movement disorders, it's not just from one category, it's from several. And you have to be able to identify which ones they are, right? Excuse me. All right, NMS, big one, especially with neuroleptics that are long acting because they're so strong. This can become life-threatening. 3 heralding signs, remember, the rigidity, profuse diaphoresis, labile blood pressure. I mean, their blood pressure's all over the place, okay? So how do we rule it out? excuse me, get the labs on them. Okay. And they're going to test positive for myoglobinuria because the body's breaking down muscle tissue. That's more young men. All right. All right. You don't need to know this part here about the smooth muscle relaxers and so forth. Okay. That's an ICU thing. That's what they'll do when they get them up to ICU. All right. Any questions about EPS? All right. Then we did ethical legal. Excuse me.
Yuko, I have one more question about the EPS stuff. So
Sure.
it is common then to, like, most people who have, you know, these movement disorders are going to have a combination of all of them. So can you give us like an example of you know, like a real life thing that you've seen where you've seen these mixed symptoms?
Usually they won't have NMS because that's an emergency, but usually you won't see that. So a little lady comes and she sits down and sits at breakfast and she's looking at you and okay. So what tell me what symptoms she's displaying from what?
The pseudo-Parkinsonism.
Very good. Very
It looks
good.
like every patient we took care of in long-term care.
Yep. What else did you see?
Rapid eye blinking.
Mm-hmm.
They were
Which
blinking.
is
Attack
which is-
a king. Oh God, I don't know.
With the tardive dyskinesia.
okay. Okay.
A cat.
What
Yeah.
about the right? The tongue thrusting. Okay. So do you see how it can be all these things, but you have to be able to look at the patient, okay, and identify exactly what it is. That's why you need to know the symptoms because they aren't going to have just one. Okay. Does that help? No, you wouldn't give a B52, Christina. You would give them the benzotropine or the Benadryl, the diphenhydramine. Okay. Yeah.
So for the treatment, it doesn't really matter like what symptoms you're seeing. It's basically the same treatment, either the diphenhydramine or the benzotropine.
Discontinue the medication or lower the dose. Either give diphenhydramine or benzotropine. With tardive dyskinesia, you can't do anything but discontinue the medication or lower the dose. Okay? It's fairly simple. It really is. So the only thing you would give the B52 for is somebody who's agitated, right? And you need to get them down. Okay? All right, you're welcome. All right, any questions about the legal and ethical? Because this is the big one, because this guides everything that we do, right? I'm afraid to give it to you guys full screen again because I lost you yesterday. So just bear with me. Okay, so you understand that in order to put a patient in the hospital against their will or to petition, the petitioner must have personal knowledge of one of these classes. Either the patient is danger to others, right? Danger to self, gravely disabled, or persistently and acutely disabled. Okay? Now, a patient can be one of these, two of these, three of these, all four of them. Okay? Okay. Any questions about that?
Yeah.
Okay.
Yuko, you said that that a person can be involuntarily committed for 72 hours
Yes.
for emergency evaluation.
Yes.
Okay, and then the Humphrey versus Cody, what was that? How is that relevant?
It's to let you know that when we hospitalize somebody against their will, we're denying them their civil rights. Right?
Okay,
especially the right to freedom.
Okay, but there basically has to be a really good reason to do that.
Right, and that's where you have to have personal knowledge of these 4 categories. A patient can be one of them, 2 of them, 3 of them, or all 4 of them.
Are you wanting us to know the different cases? Like
No.
the Humphrey? Okay.
No. All right. So don't forget that 2 psychiatrists have to stipulate or agree about the grounds for the petition. Now remember that the second psychiatrist can be somebody that the patient pays for out of pocket. Okay? Yes, suicidal ideations that would follow under the danger to self. Okay? Danger to others, wanting to kill somebody or hurt somebody, right? Gravely disabled, where they're, let's say that would be like a diabetic who doesn't take their insulin. Okay? And persistently acutely disabled, I'm sorry, I've got it reversed. Persistently acutely disabled would be the diabetic not taking their insulin. Gravely disabled would be the little old lady with advanced Alzheimer's whose executive functioning is gone, and all she does is sit on the couch, soiling herself. She doesn't eat. She doesn't take her meds because she can't function independently anymore. Okay?
So just refusing to take meds can be considered danger to self?
It can be. It depends upon the medications. Yeah, like insulin. Right? If they don't take their insulin, their blood sugar is over 1,000. Yeah, big time,
What about
right?
eating disorders?
It can be, yes. Very good. That's very good, Carly. Yeah, eating disorders can be because it's almost like a slow form of suicide, right? So yeah. Who elevates when they're brought in for 72 hours? If the petition holds, then they go on a list to be taken to court. And then that list is handled by somebody who's the court affiliate. And so they make sure that the patient goes to court. Okay? Christina, it says that there are 2 psychiatrists, but no, insurance will cover 2 if it's from the same facility. Okay? The same hospital. It won't cover the other one if the patient decides they want their own private psychiatrist to do an evaluation. Okay? You guys are asking some really good questions.
So you
I
go.
like it. Yes, ma'am.
I have a question about like Andrew Davis when he came in voluntarily for alcohol withdrawal. Could he have been brought in involuntarily if his wife brought him in?
Sure could. If he had made a threat to kill himself or to hurt somebody else, yeah, she could have brought him in under petition on those grounds. Right? All right. Writ of habeas corpus, set me free, basically. Okay. Least restrictive doctrine. Now that's a big one for us on the psych unit. We cannot put patients in their rooms and lock the doors. Yes, Natasha, you've got it right. You've got it right. Acutely disabled would be somebody who, like I said, who doesn't take their insulin. And then the gravely disabled, somebody who can't, they're cognitively, they can't function independently. Okay, they have no judgment. They can't make rational decisions. So if somebody is voluntary admit, but they're DT or DTS and they want to leave AMA, what would happen is we would call in the psychological evaluation team to do an evaluation to see whether or not they can be petitioned. If they're petitioned, then they're staying on the unit for 72 hours. Okay. Now, yes, ma'am.
I have a question. Say you have a patient admitted and they become aggressive towards staff and other patients. How do you guys handle that?
If we need to give them medications against their will, then we can get an emergency order to hold them down because they are a danger to self.
So it'd be restraining with medications, not
Right,
physical.
it'd be a chemical restraint. Yeah.
Okay.
Very good. All right, so you can only force meds on a patient if it's court ordered. Yes. You can, okay, that's a good question, Mauricio. I'm glad you asked that. Voluntary and petition patients have the right to refuse medications. Okay? Make sure you remember that. Court ordered or revoked court ordered patients cannot refuse medications. If they refuse their oral medications, you have a right to be able to hold them down and administer an IM against their will. Okay? And I gave you an example of how to write the order in this PowerPoint. All right?
What about children? Can children, the parents get to decide if the kid receives the medication, or is it up to
Yeah.
the kid? Okay.
No, it's up to the parent. And you cannot petition anybody under 18. Okay?
So how does that work then if you're bringing your own child in? It wouldn't be considered being petitioned. Would it just be that you are voluntarily bringing them in, so it would be a voluntary admit?
Yes, it's considered voluntary, but children fall under a whole different group of laws. So even though they are considered voluntary, if they become aggressive and a dangerous self, then you can get an order and hold them down against their will. But you also have to get the permission from the parent to be able to do that. Okay? And also seclusion or restraint as well. You can put them in seclusion and restraint if it's an emergency, but you have to notify the parents as to why this happened. Okay? All right. Let's see. Michael, what's an ALOC? Is that altered level of consciousness? Now, if there is an alteration any type of consciousness, then no, we're not going to act because they're not capable of making decisions. That's where we may have to find a court-appointed guardian for them, or hopefully they have a power of attorney who can make decisions for them. Okay, but basically they become incapacitated. All right, good question. Wow. Yeah, Kathy said you guys were a really inquisitive group. I'm glad. You're asking some really good questions. Right. And revoke court order, Lupita cannot refuse either. Okay, so anybody revoked. Okay. Okay, so this is another slide you guys will need to know. You will need to know how many days of inpatient time a patient who is danger to self, danger to others, persistently and acutely disabled, or gravely disabled may be hospitalized up through a year. Okay? Yes, and the nurse, you guys will get an order and the nurses will restrain. Usually we call security to help us, but they will help to restrain the patient so that you can give them the med. Usually what I do, if I have to give something against their will, I will take the PO version and I will take the injection. And I will tell them, you have lost control and I need to help you to regain that control. I brought medications to help you to calm down or to relax. I'm going to give you a choice. Would you like to take it by mouth or do you want me to give you the injection? And then I let them make the decision. So if they say I want the injection, I tell them, I'm more than happy to give you the injection, but what I'm going to ask is that you will cooperate with me, that you will lie down and allow me to give you the injection freely. Okay? And so a lot of times they will. They'll say, okay. And then they'll lie down, they'll pull down their little pants, and you give them the injection. If they're going to say, no, you're going to have to fight me, it's on like Donkey Kong. Then everybody moves in, you put them into a therapeutic hold, get them down, and then you give the injection. Okay? So I give them a choice, you know. All right. No, there are no different wristbands, and the reason is we cannot single them out, right? They have to be like everybody else. That's why we can't put people with MRSA or C. diff or scabies or head lice. We can't confine them to their room. They have the right to walk around on the unit and infect everybody else, okay? We're an equal opportunity infector, all right? You get a report as to what the status is of the patient. And over at Banner South Campus, they have what's called a tracker, which is wonderful because they give you the legal status of the patient, whether they're court ordered or voluntary or petitioned. Okay, you'll know. All right. All right. Any questions about this little slide here? No, I'm glad Natasha is asking if there's only 5 modules in D2L. When you get to module number 5 and click on it, it'll drop out to 6, 7, 8, and 9. I don't know why it did that. I fiddled with it and tried to get it to separate, but I couldn't do it. So just click on module 5 and you'll get the rest. All right, any questions about who can declare a patient incompetent? No? Okay. Ethical dilemmas, remember, taking no action is an action. Okay.
Can you elaborate on that? Like, I understand what you're saying, but I feel like there's more there that can be said about that.
Good example. Way back in the old days, we used to have to count narcotics by hand. So a friend and I are standing in there and we're counting narcotics. She takes a sleeping pill, tears it off, takes the sign-out sheet, goes out to one of the nurses getting ready to go off a night shift and says, hey, I had to waste this. Can you go ahead and sign as my witness for the waste? So the nurse signs it. She brings it back. She puts the sleeping pill in her pocket. Okay? So I'm thinking about it during report, and I think, I need to say something to her. So I hop out of report, and I go out, and by this time she sees me, and so she leaves. And I follow her out to the parking lot. She takes the pill and she throws it out into the bush. So I pick up the pill and I go back onto the unit. When I get back to the unit, my unit manager goes, I need to talk to you. So I go into her office and I said, what's up? And she said, I need the pill. And I said, what pill? She said, the one in your pocket. Oh, yeah, okay. So I pull it out and I said, when we were counting narcs, she goes, I know about it. Mickey, who was the other nurse, already told me she witnessed you take the Restoril and put it in your pocket and convince her to have the night shift nurse sign off as a waste. So, because I didn't say anything at the time, my not taking an action was considered an action, right? So I was found just as guilty. Yeah, she later admitted to it, but because I didn't do anything, I was found just as guilty as she was. Okay, does that help? Yeah. That's why I don't socialize with people I work with. No, Christina, we didn't have cameras back then. These were in the old days when we still carried narcotic keys and we still had to sign drugs out on pieces of paper. It would have been nice if we had had cameras. All right. This one's, I know you can't read.
Could you go back to the incompetency slide? I feel like, I don't know if it's me or, is the connection between that and to like the court ordered treatment where like that's what is being decided in the, in the hearing or what?
No, families may come forth and say that their father is not competent to be able to make any type of legal decisions, and so somebody needs to be appointed his guardian. So they have to go to court, and the only person who can decide whether or not that person's incompetent is going to be a judge. However, the psychiatrist is the one who does the workup to decide whether or not the patient's competent. But ultimately, it's the judge. MSW is the Master's of Social Work, or the social worker. Okay?
I guess, so once a person is declared incompetent, then like what happens to them?
Then they have either a court-appointed guardian or it's all court-appointed guardian. Then their guardian acts in their stead, makes all their decisions for them, including financial decisions. Okay? Does that help?
Yeah, it does. Thank you.
Sure. Okay. 2 ethical principles, even though you can't read them. Beneficence, do no harm. Non-malfeasance. Non-malfeasance, don't do any harm. Beneficence, do good. Okay? Any questions about that? Remember, the way to remember non-malfeasance, remember Maleficent, the Disney character? She was evil, right? So you want non-maleficent, don't do evil, okay? And beneficence has the word benefit in it. So if you benefit somebody, you do good for them, right? All right, ethical issues for us, right to refuse meds. Okay, and this tells you who can and can't. The right to least restrictive environment. Okay, so legal issues, confidentiality and right to privacy. Right, we all know that, right? HIPAA. What's the one time when HIPAA can be breached?
Tarasoff Act.
Tarasoff, you got it. All right, also known as duty to warn. Look at you, Melissa. Yeah. You are on it. Good for you. Good. All right. Remember, they have to sign informed consents for their meds, right? And then the big one. Yes.
What about if you have a child? Is there privacy from the parents as well, or can their parents know if they are threatening to harm themselves? Is that something that the psychiatrist can relate to the parents?
Yes. Sure is. Yeah. The only time that you cannot tell the parents anything is if there's a court order. Okay. Okay. Restraint seclusion. The biggest lawsuit from that is for false imprisonment. All right, we already talked about this.
Sorry, could you go back to the other slide that is the one, the ethical issues, where it has the boxes? What's with the treatment alternative? That just means, what does that, how does that all fit into?
It's supposed to be with this box, the right to least restrictive treatment alternative. So we can't confine them to the room, deny their movement, right? They have a right to be able to move around.
Okay, so those two things go together.
They go together.
And then the bottom is they can't refuse their meds, or...
This one actually goes this way.
It goes...
Okay, yeah. I couldn't get the arrows to go that way, so...
Wait, so the bottom one is left to right? Or...
Yeah, it goes top, and then to your right.
Okay, thanks.
Okay, sure. Different types of lawsuits that we face as psych nurses. Breach of confidentiality, defamation. Remember I said in the lecture, you may think something, but don't write it. Okay. A good example, there was a psychiatrist who wrote in a chart, I'll be back to talk to the patient when he's no longer being an a-hole. Don't forget, patients have the right to refuse their chart. and to read it. And so he read it, and so he sued because right there was libel. Okay. So you can think it, but like I said, don't write it down. And don't say anything in front of the patient. Okay? All right. Any questions about any of that? Christina, yeah, I think that psych nurses have more liability issues facing them because we have patients who act out and become aggressive, and we have to put our hands on them, and we have to medicate them against their will, forcibly against their will. So, yeah, I think that as a psych nurse, I practiced over 40 years in the hospital, that I think that as nurses, we're losing more and more rights to be therapeutic, and patients are getting more rights to be able to become litigious. So, other types of lawsuits, use of excessive force. Okay. Assault and battery. Y'all know the difference between assault and battery? Assault is supposed to be the verbal, battery is where you actually do, but it can be either way. Okay. Invasion of privacy. So let me tell you about a nursing student. This was a long time ago. Okay. I was working at a hospital on a weekend, and I had a patient that I was discharging home. So I'm working on his paperwork, and the tech lets in a visitor. And so the visitor comes around the nurse's station, and I look up, and here's one of my nursing students. I said, "Oh, what are you doing here?" And she says, "Oh, well, I came to pick up my boyfriend." I said, "Came to do what?" Meanwhile, the patients come down the hall. He sees her and goes, "Hey, babe, there you are." So I look at her, and she turns around to him. She goes, "This is Yuko. She is my clinical instructor." He goes, "Oh, really?" He goes, "Man, you're the one I've got to thank. If you hadn't brought her here, we would have never met." Really? He goes, "Yeah, man, that first night she called the patient phone. We talked and talked and talked." And he says, "Baby, did you get your stuff moved into the apartment? You got my information off the chart, right? Like you said you would?" Really? Yeah. Okay. So she was ousted out of the program. Okay. Because that was invasion of privacy, and there was also HIPAA. Right? So, and that also tells me there's no boundaries. Right? So, yeah. So be real careful. Okay. Okay, verbal and mental abuse, be careful about that. Physical abuse, we are such a litigious society now. I think that we look a lot of times for anything to be able to sue for. Unfortunately, assault and battery and physical abuse can result as, let's say we have two patients who are fighting, and the tech goes up and one grabs one grabs another, but they come up from behind them, right, and they put their arms around them and pull them apart. That can be assault and battery, and that can also be physical abuse on the tech's behalf. So we take classes right now over at Banner South. They're doing Evade, but you'll also hear there's classes called CPI. What was the other one? Care and Comfort or something like that, where we are trained to do what are called therapeutic holds. So this is where your charting comes in. That's going to be essential, because if you say that there were two patients engaged in a verbal and physical confrontation, one patient punched another patient in the face, which means a danger to self and a danger to others. The techs came up using therapeutic holds and were able to physically remove the patients from the situation. It depends upon your charting. Because if you say the tech grabbed this patient by the arm and the other one was grabbed by that arm, and the patient sues for assault and battery or physical abuse, saying the word grab, going to sink the ship. So you have to be real careful with your charting, okay? So, I mean, oh, yeah. Okay. Okay, so salt and battery, what is right, what's not? Yeah, CPI, Lupita, that's what it is. Yeah. False imprisonment occurs when we restrict their movement, okay? Any questions about that? No? Y'all are good? Okay. Restraint seclusion, last resort, okay? You can never have the word PRN with the word restraint, seclusion, okay? And then I give you orders. Natasha, the way you're going to separate those is going to be by your charting and your verbiage in your charting. Yes, Christina, you need an order for last resort. You have to, before you can put a patient restraints, you have to say what you did to try to diffuse the situation, whether or not it was successful, and then what led up to the restraints, what behaviors led to the restraints, and then what behaviors are going to lead to the release of the restraints. Okay? Good question. All right. Here's your legal question, legal orders, the way they should be written. Okay? How do we avoid being sued? Document everything. I put people's names in the chart too. Okay? Make sure you adhere to the nursing process. Usually, Christina, what happens is if I have to put a patient in restraints, there's going to be at least 2 or 3 nurses. I will say, let's get him into the restraint room and let's get the restraints on him. I'll look at another nurse and say, call the doctor and get the restraint order for me. Okay, so it's all simultaneously. Okay, and then another nurse, I'll say, get the restraint order, also get me a chemical restraint order. Okay. You check, when the patient goes on seclusion or restraint, they're on a 1-to-1. Okay, so they're constantly being monitored. If they go on restraints, you check their circulation and their skin every 15 minutes. And you also do vital signs. Right, we need to make sure they're still breathing. Okay? Okay, so in what position do we restrain patients?
On their back.
Very good. Ideally, when you have them on your back with the arms, you're going to restrain them like this. One arm up, one arm down. Ideally. But that doesn't always work. A lot of times the restraints are down here at the waist, so that's where you're going to restrain them. How often do you need to release those restraints?
Every half hour.
Very good. Can I release both leg restraints at once? No. It's one extremity at a time, Melissa, but it's going to be one opposite. So at the same time, I'll release like the left leg, right arm. Okay? All right. Licensure. Don't forget, when you get your RN license, you belong to the State Board of Nursing. Hold on, I'm reading something. Okay, so Natasha, yes, on slide 17, let me go back to slide 17. Hold on. This slide right here, these are all orders that are not legal. Okay? And then this slide are all the orders that are legal. Okay? All right. Once you get your license, y'all belong to State Board of Nursing 24 hours, 7 days a week. Okay? Y'all understand about the Can Do program? Don't ever get there, please. If you're caught diverting narcotics or controlled substances from work, then what will happen is you will have to go through the Can Do program and you'll be placed on 3 years of monitored probation, where you're going to have an RN supervisor monitor you every month for 3 years. You will not be able to work any place where there's any type of controlled substance. You tell me as a nurse, where are you going to work where there's nothing that's controlled? You can't even work at the zoo. Right? Can't do home health. Can't work in a clinic. Okay, so where are you going to go work? All right, so just be real careful, protect your license. Insurance company, that's about it, Michael. Yeah, that's a good idea. Prior auth department, oh, and all that paperwork. Oh. Okay, we talked about Tarasoff, right? Any questions about Tarasoff? Y'all understand it completely? I don't know why things do the way they do. Anyway.
So, we're mandatory reporters. I don't know if this has anything to do with it, but we're mandatory reporters for child abuse and elderly abuse. But if a woman comes and she's come into like the psych and she's been abused, we can't report that. That's not considered okay.
No.
But if she's physically doing harm to someone else, that's when we can report it. Okay. Or someone okay.
Yeah.
Okay.
Yeah. Even if you suspect. So let me give you a good example of a ethical dilemma. Long time ago in California, I happened to do a psych eval on a elementary school bus driver who reported to me that by 5:30 in the morning, she was completely intoxicated on alcohol and very high on cocaine. It was causing a problem because at one point she had pinned a boy between the bus and a tree, elementary school kid, okay, because she was high. Another time, she was coming off of everything and needed to take a nap. So she pulled over with a bus full of children and took a nap on a busy freeway. One of the children got the door open, and when she woke up, half the kids were gone. And she couldn't find them. Luckily, they were all hiking it down the highway. They were going to go home. So she was able to get them back on the bus. And she's laughing about all of this. So I was really upset because, number one, I can't violate HIPAA because back then, Tarasoff didn't pertain to anybody who was being threatened in any way. It only pertained to judges. So I went back to my unit and called the doctor. Fortunately for me, my coworker was an off-duty sheriff's deputy. And so when I was getting ready to call the doctor, I said, why don't you come and sit in the nurse's station with me, because we had cameras. I said, so you can watch the cameras while I call the doctor and give him a report on this eval. So I gave the doctor the report, and the doctor said, well, call the school, a reporter. And I said, I can't because of HIPAA. And he goes, oh, yeah. So I turned around and I looked at my coworker, and he just nodded his head. So somehow, some way, somebody made an anonymous call to the school and reported it. So, but it was a bad dilemma because, I mean, what if one more child got injured by her or so forth? So yeah, sometimes you get in those dilemmas and you just don't know what to do. But yeah, thank goodness it worked out. All right. Christina, would I? Yes. In a heartbeat, I would have. Child abuse reporting, I don't ask you anything about children if I can prevent it. The only time I will be about ADHD. But just realize that we have to report child abuse to the Department of Child and Family Services. Regardless of whether or not you think that they're going to do anything, that's not your call, you still report it, okay? You do not let the child leave with the individuals unless DCFS says it's an okay thing, all right? But usually in child abuse reporting is going to be done either by the physician or the social worker on your unit, okay? All right. So thank goodness in Arizona, we can do it anonymously, which is wonderful. Okay. Restraint and seclusion. Patients were not treated very nicely. They were used for experiments. They did frontal lobotomies on a lot of them. They euthanized a lot of people. I mean, if any of you watched the series Ratched, you'll see a lot of the things that were done to patients, like patients back then. Okay. Remember that restraint and seclusion, last resort. Okay. In Arizona, the max time for an adult to be in restraints is 3 hours. You don't need to know this, I'm just telling you. And a child, adolescent, 2 hours, and a child is 1 hour. Okay, so there are time limits. You can't leave them in forever and ever. Okay, so you've got to specify the type of restraints, and it's going to be mechanical restraints. Usually they're neoprene, so they're soft, but I still always put a washcloth between the neoprene and their skin, so that when they pull, it doesn't tear their skin. All right. Okay.
You go.
Yes.
If a patient is put on restraints, are they put in like a separate area so other patients, like you're saying, people can just walk around so no one can just come and like disturb them? They're like on a wall. Okay.
That's a great question. Yes, there is a separate hallway with usually two or more restraint rooms. Now, restraint beds are totally different. They're metal beds and they're bolted to the floor. And they have slots through them where you can put the restraints through. And there's cameras in the room. They also have their own separate bathroom in the hallway. But yes, they are moved away from the general population where they can't be seen. Okay? Good question. Excellent. All right. Y'all want to see if we can get this video working? Y'all want 5 minutes so you can go to the bathroom? Whatever?
Yes, David.
Okay, good. Go ahead and go because it'll take me 5 minutes to figure out this. Let me see if I can get this to work. Okay, Brawley, you need to tell me if you can hear this. Did you hear it? No? Let's try this one. All right. I may have to lose you guys. Hold on, I'm seeing if it'll play. Did you hear it? If you're shaking your head, Brawley, I can't see you.
No, I can't hear it. Sorry.
Crud. Dang it. I wonder if I turn off my microphone.
I can't hear it.
I guess you guys are just going to have to see it. I did post it on the page, so I will need you guys to watch it. It's really going to help you with the antipsychotics. All right, so I'll wait till everybody get back. Oh, there's the video. Natasha posted it for me. All right, let me wait for everybody to get back so I can release all of you officially.
In this lecture, we are going to cover pharmacology of antipsychotic.
All right, who did that? It's a really good video. Good. Yeah.
I didn't know my mic was on, sorry.
That's okay. It's really good. So I will keep looking for little things like that to help you guys. All right, I just need to remember to do it for the other class too. But all right, you guys are doing okay though with everything?
It's
all right.
a lot.
It is. It's an awful lot.
I feel like it's really helpful just to keep listening to the lectures.
Okay.
Yeah.
Don't forget, I am here to help you. Okay? If you have questions, let me know. Text me for an appointment and I will get together with you.
Hugo?
Right? Yes.
Hi, sorry. Are
Hi.
we watching the... Hi there. Are we watching the video and then coming back to this meeting? Is that what we're doing?
No, I'll release you guys to go ahead and watch the video.
Oh,
But
okay.
I want to wait till everybody gets back.
Oh, I see. Okay, thanks.
Yuko, I really appreciate you going through the PowerPoints, like slide by slide, and asking us questions.
Oh, good.
That is 100% helpful.
Okay.
We haven't had that in our last rotation, so it's
Well,
extremely helpful. Thank you.
I don't want to get accused of lecturing.
No, you're not at all, but it's 100% helpful. So
Good,
we're all
I'm
on the
glad.
same page when we're discussing about something. If we have questions, where we can all pull it up and look at the same thing.
Good. And this is all the stuff, I do that for the stuff that is really relevant to the exam. Okay?
Thank you.
And then in lecture number 9, it's a very light lecture. Okay? We will go back through whatever you need to go back through. Okay? That's my review. All right. Don't forget psych math, piece of cake. All right. You all have your whiteboards? Anybody who doesn't have a whiteboard? Okay. All right. Y'all got your picture taken? Is the thing?
Do we have to retake it when we
No.
do this rotation now? No.
No.
Yuko, I just have a question because I want to clarify showing the whiteboard during the exam. You press begin exam and it starts timing and then you show it? Because Kathy told me I showed it way too early and I showed the room way too early.
Really?
Yeah, I didn't.
I guess, yeah, just hold it up. Like
Yeah,
that.
and then show the
Flip it
room.
over. Yeah.
Okay.
Mm,
It
yeah.
says like monitoring on top. Is that how you
Yeah.
know? Okay. Because Kathy's like, you showed it way too early.
And so
I don't know. It was our first time.
What if our camera is attached to our computer? Are we supposed to lift up our entire screen? And because I mean, I'm not going to have enough space for the wiring that's connected to the desktop.
Can you just turn your monitor?
Yeah, but it's
That's
not
what
going
I would do.
to hit the back wall though.
Oh, well, I would just tell them it's against the wall and, just kind of pivot it to the left a little, pivot it to the right and saying, this is the room.
Okay.
Yeah.
And then, I mean, I don't know how much slack I'm going to have. I mean, I get as much as I can. But so when that starts, it starts the exam. So we're on question number 1 when we show the whiteboard and the scan room. There's no like in between time to do it. So does that take away time from our exam then?
It does, yeah, but just flash it real fast.
Yeah, but that's scanning the room too.
Yeah, that should take about 30 seconds.
30 seconds for a 60
I
minute.
know. Yeah, I hear you. It's not a perfect system. I wish I had better answers for you. So, unplug and plug back in. That's what I did. Oh, okay. I guess that makes sense. All right. So here's what I'm going to do. I'm going to release you guys. I want you to watch this video, please. It's going to be beneficial to you. It's going to help you to understand about the medications, specifically about dopamine and everything. It will give you a good foundation to be able to help you to remember the meds. So I'm going to release you to watch this video, okay? Otherwise, I will see you guys in lecture, well, not lecture, but clinical, all right? Please remember that our lectures are always going to be at 11 o'clock in the morning. Your group will stay at 11 o'clock in the morning throughout the semester, okay? We're the ones who rotate. You guys don't. So your lectures are always at 11 o'clock, okay? The exam with me is always going to be at 11 o'clock, okay? Any questions? If you get